So let's begin with the lecture. Um, uh, if you guys remember, you have covered a part of this, the normal urine in 1.3. How many of you remember that?
Yes, doctor, we remember.
You have it in 1.3. Remember that we talked about the normal constituents of the urine. So these normal constituents, sometimes some of them can become abnormal if their quantity increase or decrease. So in the first one, we just had in the first year you had a normal constituents. In now you will have the abnormal constituents, and in the third year you will actually perform the urine analysis with the dipstick method, the routine method that is followed in the hospital. So here we are going to only discuss some of the abnormalities that can arise in the urine. We will mention some of the diseases also, but there is no need to go into the detail of those diseases. Okay, so let's start. So the constituents of the urine, normal constituents are divided into organic and the inorganic, or the organic ones are non-protein in nature or the protein in nature. Sometimes the proteins are also there are some proteins that can be present, but if their quantity increase, that is very dangerous. We shall see that. The inorganic ones are the chloride, phosphate, sulfate, and the carbon. Usually, not all of them are measured. Only the phosphate and the chloride one are the parameter that are measured regularly. So, as for the abnormal constituents, which usually they are not present and they should not be present, and if they are present, we call them the abnormal constituents of the urine. For example, sugar, protein, that is their concentration becomes very high. Though normally none of them are there, but sometime you can have a couple of them. But if their concentration are very high, and you also need some time to have a special examination for the presence or for the detection of what type of proteins are present, then you will of course label it as a abnormal constituents of the urine. Ketone bodies normally never, except when you are fasting for a long time, that can be a normal, but usually they indicate sometime as an indicator of severe diabetes mellitus or uncontrolled diabetes mellitus. So that is why they are not usually there. But sometime, if you are fasting for a long time, like 1 or 2 days, then you can have, for example, when the Muslim fast in the month of Ramadan, at the end of the day, there is a possibility that you can have a ketone bodies in your urine. The third one is bilirubin and the bile. This bilirubin and the bile, they are normally there, but their concentration is very low. So their concentration can increase, and that can become from normal to abnormal. Blood, normally it is not there. Sometimes the stone, they are of course not there, but sometimes they can come in the form of crystal, or sometimes the small stone can also appear in the urine, so that we count it as abnormal constituent of the urine. So if we look at the composition of the urine, it is mostly it composes of ammonia, sulfate, phosphate, chloride, and magnesium, calcium, potassium. These are the normal constituent, some of them, but their concentration varies, and if their concentration changes, that can be a problem. 95% of it is usually the water, and their concentration are given here also. In this is in percentage of the urine, and this is in gram, and actually this is what is written in the report also. 0.6 gram bicarbonate, 1.2 gram creatinine, potassium, sodium, chloride ion, urea. As I told you, it is basically the chloride ion, sodium ion, urea, potassium, creatinine. These are the ones that are regularly measured. uh, Very rarely we do the measure of the phosphate, the sulfate, but these are the things which are more or less usually measured in the normal or considered as a normal constituents. These are some of the terms we use when we are considering the abnormality of the urine. For example, if there is a large quantity of albumin present in the urine, we call it a albuminuria. So this is a medical term that we use to classify the presence of the protein in the urine. If it is only albumin, we call it albuminuria. Similarly, if there is a presence of glucose, we call it a glucouria. If there is erythrocyte, mind you, I'm talking about the erythrocyte, not the blood. Blood as a whole, it can be called something else, but this is the presence of the erythrocyte. We call it a hematuria. If there is a leukocyte, we call it a pyuria. Ketones, we call it a acetonuria, and if there are a large amount of proteins present, we call it a proteinuria. So these are the different terms that we use to classify the abnormality in the urine. You have to keep in mind all these terms and their abnormalities. So this is to refresh your memory. Who can explain a little bit about this one? What actually is going on here, why and what this structure is all about?
May I?
Yeah, please.
The glomerular with the capillaries and the tubules.
Glomerular. What do you call this whole thing?
The whole thing, the nephron.
Nephron, yes, it is a one nephron, and then you have the parts of the nephron. The first part, as you said, is a
glomerular.
Yes, and then
the tubules, proximal tubule, and then lobe of Henle,
yes,
distal, and the connecting duct.
Yes. Each of this part has a very specific function to perform, and you have learned all of it in the first year in 1.3. What how the nephron is functioning, what are the different part, and at what part what is actually happening, the specific function. So this is only to refresh your memory, and I'm not going to go into the details here again. You can revise your 1.3 back at home. So again, this is the more or less the same thing, the process of formation of the urine. You have a filtration going on. Here is the glomerular. Okay, this is called glomerular filtration. Then at the proximal convoluted tubule, you have the tubular reabsorption. So all the things that are filtered here, most of the things that are filtered here, they are reabsorbed here in the proximal convoluted tubule. And for this, that is what is mentioned here. The glucose, amino acid, potassium, calcium, water. Water is actually constantly taken or reabsorbed at different other parts of the nephron also, but mostly it is done here. The reabsorption is done here in the proximal convoluted tubule. That is called tubular reabsorption. And the loop of Henle, there is concentration going on. The become the urine gets more and more concentrated, and if the concentration are very high of something, then there is a tubular secretion going on. That is, it is basically absorbing the things again in the distal convoluted tubule, and then it moves into the collecting duct, where there is again the final reabsorption of the water taking place. on the amount of water there is in our body, or there is a hormone also which is involved here in the reabsorption of water from the collecting duct, and then finally the urine is concentrated and then it is excreted via the urinary bladder, and then there is a urethra that expels the urine. So that was about the refresh your memory and some words about the of the mechanism of the nephron. What are the chemical characteristics of the urine? For example, if there is a protein which is normally not found in the urine, sometime there is something called orthostatic proteinuria. That is, if you are standing for a long time, you may have some of, but normally it is not there. Then you can have the proteins can have in the urine if there is a very severe fever, if you perform some sort of hard exercise in the pregnancy, or in some sort of special diseases, the kidney diseases, the protein can be present, and that can be dangerous. But in these ones, for example, a fever, a hard exercise, and during the pregnancy, that is somewhat considered a normal. But if there is any other associated disease with these things, fever and hard exercise, or during the pregnancy, then that can be an alarming condition. Glucose, typically it is not found in the urine, but it also depends on the type of the sugar. Normally there is very little or no glucose in the urine. When the blood sugar level is very high, for example in diabetes mellitus, it can reach about 300 or 400. So if it crosses the 400, that is what we call a threshold of the glucose. And if it crosses the blood glucose is more than 400, then it begins to come in the urine also. So that can be considered abnormal. So glucose can also be found in the urine when the kidneys are damaged or diseased. So it is not only, mind you, this is very important here. Number one, glucose can be present if there is a blood sugar level is very high. Number two, if there is any damage to the kidney, or if your kidneys are diseased, then even if you have a normal glucose in the urine, it will still come in the normal glucose in the blood, it will still come in the urine also. So you can have a two possibility for the presence of a glucose in the urine. Number one, if the blood glucose is very high. Number two, if your blood glucose is normal, but there is a damage to the kidney, that can also leak the glucose into the urine. Nitrates are usually seen when there is a bacteria that causes a UTI. Urinary tract infection is often abbreviated as UTI. It makes an enzyme that changes the urinary nitrate to nitrite. So these are converted, and then these nitrites can be detected. So this will happen if there is a bacteria present, and that means there is an infection. So if there is an increase of nitrites in the blood, that means there is a bacterial infection present in the kidney, in the urinary bladder, in the urethra, or in the ureter. So it is possible to have at one of the place or at all of the place. So depending upon the condition. So why is this? It is like this because the bacteria which is present, which can be present in the due to some infection, it has an enzyme. And what does this enzyme do? It converts the urinary nitrate to nitrite. So it is easy to measure a nitrate. Nitrates cannot be or it is usually not measured. Nitrites are measured, and that indicates the infection. If it is only nitrate is high, and if the nitrite is not there, that means it is more or less normal stuff. Nitrates are usually there. Leukocyte esterase, again, it is linked to the nitrite condition. WBC esterase. Leukocyte esterase shows the leukocyte white blood cell in the urine. So if there is this enzyme, the activity of this enzyme is detected in the urine, that means not only red blood cell, there is a possibility that the WBC are also present in the urine. So that is an indicator of some more infection going on, or some more leakage of WBC in the urine. Maybe it can be along with the RBC, or it can be just the infection. The ketones are as I said, they are or you have studied it in the first year also. Even in the PY, they are the breakdown of the fatty acid, and once they are in large quantity in the blood, they would definitely come in the urine also, and they are passed in the urine, and it can be easily detected. If there are large concentration of it in the urine, the condition like diabetic ketoacidosis can be present, because this diabetic ketoacidosis means there is diabetic. The patient is diabetic already, and his condition is bad. His sugar level are very high, and it is not well maintained. His sugar levels are not well maintained. He is not taking the anti-diabetic drug properly, or it has been aggravated somehow. So ketones basically indicate the uncontrolled diabetes, that the person is suffering from uncontrolled diabetes. When you are taking a diet which is low in sugar, then you can also have a ketone body. For example, as I said, when we are fasting in the month of Ramadan, by the evening, there is a chance that we may have a ketone bodies present in our urine or in our blood. For example, it is, as it is written here also, starvation. That is when we starve during the month of Ramadan, or if there is a severe vomiting, then also you can have a ketone present in the urine. So these are some of the characteristics of these abnormalities, and what are the condition. And you have to know each one of them, and with their example and with their condition. So, continuing with some more abnormal constituents, as we have already spoken of the ketonuria, it is common in uncontrolled diabetes mellitus. I told you that ketonuria is present in the diabetes mellitus, starvation, vomiting for the long time. These are their values. You do not have to know these values, but somehow you must know at least it is negative. If it is, then it is normal. Hematuria, that is presence of red blood cell in the urine. Normally, it is not there. This The abnormality, if there is a red blood cell, it can indicate some sort of stone, or some sort of tumor, or some sort of leakage, or some sort of clotting problem can indicate, and this requires a further confirmation. So this can be seen under the microscope, the red blood cell. Similarly, you have a hemoglobinuria. Now, there is a difference between hematuria and hemoglobinuria, because hemoglobin is present in the red blood cell. So it can happen that the red blood cell are broken, and the content of it are present in the urine. Not the whole red blood cell are present. Their contents are present. So presence of hemoglobin in the urine due to rupturing of the red blood cell. Red blood cell are somehow broken during the passage through the nephron, and then those content, those hemoglobin, they can be detected in the urine, and that can cause hemoglobin urea. And it can occur, for example, in malaria, jaundice, hemolytic jaundice, yellow fever, and the typhoid. So these are the examples of the hemoglobin urea. Now, someone wants to join in now, and I will not allow him now. There is no time now. So if you tell me please allow this and that person, please don't do that now. So those were some of the features that we discussed so far. Now we will see some of the chemical analysis, how how these things are actually analyzed: ketonuria, hematuria, hemoglobinuria, protein, glucose, nitrate, leukocyte. So how these things are are analyzed here. Initially, what we used to do, for example, before or in the 19th century, we used to perform the test. For example, test for glucose, test for albumin, test for ketone body. So every one of them has a specific test, and that would take at least, to do this 1, 2, 3 test, you have to have at least 1 hour. It would take a long time, and there are many categories of these tests. For example, the test for glucose is called a Benedict test, and it is performed, and there is a presence of the color, and then indicate the presence of the glucose in the urine. So it will take a lot of time. For example, if you see here, take 5 ml of Benedict reagent, mix it with this one, then heat it, and then you will see such a color, and that is it will take a lot of time. So but you must know what is this test, and what is the name of this test that was earlier used for the detection of glucose in the urine. Now, test for the albumin, for example, you can do a sulfosalicylic acid test, heat coagulation test, Haller's nitric acid test. So all these are the 3 different tests which can be used for the detection of the albumin, or they were used. Nowadays, they are not used, except in the remote area you can do the heat coagulation test, but these ones are not any are no longer used. There are now different ways to have the quick result for the presence of the protein like albumin. So this is are the 3 tests that were used uh, previously for the detection of the albumin. For the detection of the ketone bodies, you have the Rothra's test. It is called Rothra's test. So here, if you read it here, take 5 ml of urine sample, saturate it, mix it with ammonium sulfate, shake it, take 2 drops of 5%. So you can see it is quite a cumbersome process. It requires a time. So each test of this would require at least 15 to 20 minutes to finish and to give the result. So it was very lengthy procedure to find out the abnormality in the urine. So this is an example of Benedict test that we spoke here. So if you look at, this is actually the Benedict test. So if you are performing the test and the end result is blue solution, that means there is nothing, there is no glucose present in the urine. If it is a green or yellow precipitate, then you can say there is some amount of sugar present, but not much amount of sugar is present. If it is orange color, that means a slightly more sugar is present. So we can say that this is a 0, this is +1, this is +1, this is +2, and if it is brick red color, that means large amount of reducing sugar are present. So this is +3. You may have seen in some of the sugar, in some of the urine analysis, there the plus are written there front of something, front of, for example, glucose also. Sometimes they write plus, 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 plus. So if it is 1 plus, that means a very small amount of glucose is there in the urine. If it is 2 plus or 3 plus, you can have a somewhat increased amount of glucose present in the urine. And if it is 4 or 5 plus, that is a large amount of glucose is present in the. So this is how they used to do the Benedict test. So for every test, you have to perform it separately to find out what color does it come about in the Benedict test, and then only you can decide how much of glucose is present in the urine. So this was the Benedict test. They used to do it before. Nowadays, it is no longer there. What do we have? We call it a urine strip. This is called urine strip test. So in this one strip, you can measure glucose, bilirubin, ketone, specific gravity, blood, pH, protein, urobiology, nitrite, and leukocyte. So all these things are normally not there, more or less. But sometimes if they are there, their concentration can increase. And if their concentration increase, these colors which you see here, they would appear differently. If, for example, the glucose is more, then this color would change. For example, if the bilirubin is more, this color will change. So change in the color of this strip will tell you how much of what is present. In our next slide, maybe you will see here, it is written here, it is reported as in concentration milligram in some cases, but or it is written as small, moderate, or large, or it is using the plus system, +1, +2, +3, +4. So if it is written +4, that means a large quantity of the sugar is present. If there is a +3, that means there is a moderate amount of, and if it is +2, a very less, or in case of +1, it is not present. Or in some cases, we used to say it positive, negative, or normal. So these are the different things that you see in the report of a urine analysis. In concentration, sometime it is written here. For example, if you see here, in concentration is written here, for example, 55 or 1000 milligram, or 55 millimole per deciliter. So all these things you can see on the on this tube, which is it is actually printed on the box, and this is the urine strip. I don't remember if I had showed you this strip in the 1.3, but definitely in 3. When you are in the third year in the 3.2, then you will definitely perform it, and then you will understand it. So these are the different ways to express the result by using the urine analysis. First, they used to check it with a comparison method, but now they have an automated urine testing machine also. So you do the test on this strip, then you put the test here, then you put the strip here inside the machine, and it is going to print here all the things here. What are the abnormalities? What are the normal things which are present here? So this is automated urine reading strip. So in like 1 minute, you can get all these values. Even less than 1 minute, it will give you all these value. And previously, it would take 1 hour to perform 1, 2, and 3 tests. So it was quite a cumbersome process, and it requires a large amount of effort also, and large amount of resources also. But now it is all automated, and within 1 minute, you can get all the reports of all these parameter in the urine. So this is the strip that is used here, okay, and you can see here the leukocyte for 120, within 120 second it will give you the result. So at the maximum it is 120 second. That is roughly 2 minutes. In 2 minutes you will get all the result of this one, and you can see here all the things are mentioned here. For example, the nitrate, it is either positive or it is negative. If it is white color, it is negative. If it is pink color, it is positive. Urobilinogen, you can see here, it is +1, +2, and +3. And at the top, you can also read the concentration. For example, 16, 32, 64, 128 micromole per liter. So you can either report it with a +1, +2, +3 system, or with a concentration given at the top. Similarly, the protein concentration is given here. I want to show you the glucose here. It is at the bottom here. If it is this color, it is negative. If it is a very small amount, we write it as traces, +1, +2, +3, +4. And at the top, you can read the concentration also, 5 millimole per liter, 15, 30, 60, 110 millimole per liter. Similarly, if you look at here, the bilirubin, they are small, moderate, or large. So there are different ways to express the strip method, the result of the strip method. But as I told you, now it is done by the machine. So you just put the strip here, and it is going to print all the parameters here on the paper, and you can easily give it to the patient with his or her name on the on it. Any questions till here?
No, so far so clear.
Is it so far so clear, or it is not clear at all?
It is clear.
It is clear. So you can get any questions regarding anything. All these slides that I'm showing you, they are important for your final exam. So some of the clinical orientation, for example, if there is a large amount of uric acid, we call it a gout. We have measured the uric acid here. If you remember here, the uric acid is not shown here, but you can measure it with the strip also. There are different companies which are making the different types of the strip. So in some of the strip, it is usually there, the uric acid. So if there is increased amount of uric acid, there can be a disease called gout, or it can be called a Wilson disease. These are the two examples of the increased amount of uric acid. The oxalic acid, normally it is not seen, but if it is seen, then if it is measured or detected, you can say it is diabetes mellitus, liver disease. So if there is increased amino acid urea, that is, there is amino acids are there in the large quantity in the urine. We call this a Fanconi syndrome or the Wilson disease. Or there is some muscle problem, there is a breakdown of the muscle tissue, so we call this a Fanconi syndrome or the Wilson disease. Similarly, the protein urea is associated with degenerative lesions. There can be a problem with the kidney, there can be a problem with the ureter, bladder, prostate, or bleeding somewhere in the genitourinary tract. That can also cause some sort of protein and some sort of blood also come in the urine. So we call this a protein urea or the hematuria. So these are the different clinical condition. At least remember one of them for each. Now, this was the chemical examination, and it is very simple examination. And nowadays, just one strip, within 2 minutes, you get the whole result. Now, some microscopic findings. What are the, sometimes we need to have the microscopic examination of the urine. So we basically concentrate uh, uh, we basically concentrate the small amount of urine, and we take it from the bottom of it, and then we make a slide of it, and then we measure it, or then we see it under the microscope. So per high power field, that means we write it as HPF, high power field, that is 400 times the zoom in. So you are basically, with the microscope, you are zooming on the slide 400 times of the size. That is called HPF, high power field. And this high power field, we can see more than the erythrocyte can be seen, the leukocyte can be seen, the renal tubular cell can be seen. Sometimes some of the bacteria also you can see, but this is very rare. But these can be seen with a high power field. So you must know what are the things that you can see with the HPF. Similarly, low power field, that is a 200 zoom, 200 times the zoom. So you can see some of the hyaline cast, granular cast, and some of the squamous cell, the RBCs, the WBCs. So they can be sometimes seen in the form of the cast. It is cast. Here it is the simple, the separate cell, the separate erythrocyte, separate leukocyte. But here it is the cast. I will show you in a while what does the cast mean here. So the presence of these things will tell you when you are doing the microscopic examination. You can see some of the yeast, some of the parasites, some of the pathological crystal, for example, cystine crystal, leucine crystal, and tyrosine crystal. So if you see a cystine crystal in a large quantity, leucine crystal in the large quantity, tyrosine crystal in the large quantity, you know what are these cystine, leucine, and tyrosine? What are these?
Amino acids.
So these are the amino acid. So let's go here and find out what is the disease that one can have. Who will tell me?
Fanconi syndrome.
Fanconi syndrome, yes, because increased amino acid urea. Basically, the crystal would be formed if the amino acid are there. So you can say there is a Fanconi syndrome, or there is a Wilson disease, or there is a muscular dystrophy. Okay.
Yes.
So similarly, large amount of uric acid or calcium oxalate crystal. For example, we spoke about the uric acid in our last slide. For example, here uric acid, you can have a gout or the Wilson disease. So similarly, if you see these crystals, sometimes these calcium crystal, they are normal, but if they are in large quantity, that indicates that the patient or someone can have a chance of forming the stone in the kidney or stone in the bladder or anywhere along the tract. Some more microscopic examination where we see the cells, for example, the erythrocytes, when we see they are dysmorphic versus normal. What does that mean? That means the shape of the red blood cell uh, is usually a disc-like. If you see here, I showed you here disc-like. See here, this is a disc-like. I will show you the real picture also. This is a disc-like. But if it is distorted, if it is not proper, if it is broken cell, then we call it distorted or dysmorphic. Sorry, dysmorphic versus normal. So this you can see under the HPF. If there are more than 10 per high power field, you can say that these are the erythrocyte, and you can then find out what is the problem here. Leukocyte, neutrophil, you can see the eosinophil. So all these things can be present. Epithelial cell, squamous cell, renal tubular cell, transitional epithelial cell. So all these things can be seen under the microscope, and only the specialist people or the person who have examined like more than 100 of the urine sample, then only you can identify these things. Similarly, the oval fat bodies can also be seen, so that also indicate that there is some problem with nephron. So this is, for example, the shape of the red blood cell in the urine. So you can see here a large number of the urine, a large number of red blood cell are present in the urine, and they are normal in shape. Normal in shape. If you see here, there is a small hole in the middle of all of them. So that means what? These red blood cell are not necessary that they are coming from the right from the kidney. They can be coming from anywhere downstream, because when the red blood cell passes through the loop of Henle, mostly they are broken up. They are not. They will no longer be in normal shape. So that means they are coming somewhere distal to the loop of Henle. Okay. So this is how you will differentiate if uh, the shape of the red blood cell will tell you if it is dysmorphic or the normal, and similarly you can conclude if it is proximal or distal to the loop of Henle. Similarly, you can see here WBC. These are all the WBCs, and you can clearly see they have many nucleus, multi lobulated nucleus. You can see in some of them, and this is WBC. Similarly, if we go on, these are the epithelial cell. You see there circular epithelial cell, cuboidal also. Sometimes you can see these are the epithelial cell, and they are with the special dye or with the stain. You can clearly identify them. Similarly, these are the transitional cell. These are the transitional cell. These are the cells that change the shape depending upon the condition. For example, in our urinary bladder, it has many transitional cell. Depending upon the stretch of the urinary bladder, the cell will change its shape. So this indicates that something is wrong in the urinary bladder if these cells are present in the urine in a large quantity. For example, these are the fat bodies. You can see here, these are the fat bodies with the adjustment of the light. You can see their polarization of the due to the polarization of the light. You can see them in a different color, the oval fat bodies. So sometime this microscopic uh, examination for example, when you are seeing some sort of bacteria which is in 10 high, if you see them 10 in number under HPF, you can clearly say that these are the bacteria or some sort of yeast. Sometimes are also present. Sometimes the viruses, for example, CME, cytomegalovirus, can also be present in the urine. So all these things are possible to see under the microscope. You have to have a very expert hand, and you have to have a large experience to take a look at these things. However, you have to know only the theory of this one. So, for example, these are the bacteria which are clumped together. You can see them in the picture here on the slide here. Uh, these are the yeast cell. You know, the yeast, they have this fungi-like appearance. Okay, so they are like they have this tube-like cell, and then they have this budding of spores, and you can label them as fungi. Now, the difference between caste. What is actually a caste? A caste, I will show you in the next slide what does the caste look like. So you can have the erythrocyte caste, and this erythrocyte caste will indicate some there is some glomerular disease is present. So it is before the loop of the Henle. Leukocyte caste will indicate a pyuria or some glomerular disease is present. Degenerating casts, that is, they would degenerate as the time passed by. So you can have granular cast, hyaline cast, waxy cast, fatty acid cast. So all these are non-specific, except the fatty cast, which you can see in the nephrotic syndrome, or some sort of tam horsefall protein. These are the names of the some of the special granular casts which are attached to this special protein. However, they are non-specific and does not indicate much of any disease. But you must know their shape. And now I will show you the shape. For example, this is a red blood cell cast. So cast is actually, I will take you back to our uh, uh, the first or the second slide. So before that, just take a look at this long thing. It is a long thing, and these are all red blood cell, and they are all clumped together. So this you can see under the microscope actually, and it will be in this shape only. Cast means something is has been casted. Okay, they are cast here in the cast of the red blood cell. Similarly, you can have a cast of the WBC. These are the cast of the WBC, and these are the cast of the granular cast. You can see here some of the the WBC, those who have the granules, we call them granular cast, and these are the hyaline cast. You can see here they don't have anything. They are just the fingerprint of the loop of Henle. Cast are actually formed in mostly the loop of the Henle. And before I go to this crystal formation, I want to take you back to my first or second slide to show you or to explain you with how does the cast actually form. So here, uh, you see here, all the things would be filtered here. For example, let's say if there is a red blood cell coming from here, okay, red blood cell will come here, and they are going to get together. They are going to get clumped here, because this loop of Henle is very small, and it will not allow much of the RBCs to go ahead. So all the things, all the red blood cell, they will clump here. They will make a fingerprint of this loop of the Henle. Okay, so they are going to make all of them are clumping upon one and another. So what happens when the things are good? The urine will come from here, or the large amount of water will come here, and this clumped red blood cell, they are going to be pushed forward, and it is going to go out, and then it is going to come out in the urinary bladder, and then it is going to come out, and then you can see it under the microscope. So basically all are forming here. There is a problem. It can be a problem here, or it can be a problem there somewhere. So if in the case of the red blood cell, for example, if too much of red blood cell are coming from here, they are not going to go ahead. So all of them are going to clump here. When there is a pressure of urine coming out from this proximal convoluted tubule, they are going to push all the red blood cell, and the whole thing is going to come out in the urine as such, the whole thing. So basically they are a fingerprint of the loop of Handle. These casts are basically the fingerprint of this loop of Handle. So now you know how the casts are formed, and these are the different shape of the cast and their color. This is the red blood cell cast, WBC cast, granular cast, hyaline cast. So now I'm going to talk about the microscopic examination. We are going to see some of the crystals that can be detected in the urine. Any questions still so far?
No, very clear.
No, Doctor, thank you.
Microscopic examination, the crystals. So these are you can have a urate crystal, which can be ammonium biurate or the uric acid. You can have a triple phosphate, calcium oxalate, amino acid crystal, for example, cysteine, leucine, tyrosine, sulfonamide crystal. So all these are the different types of the crystal which you can see under the microscope. And now I'm going to show you some of the important uh, crystals. So you must keep their shape in your mind. For example, the calcium oxalate crystal. So these are the calcium oxalate crystal. When you see them under the microscope, they appear like this calcium oxalate. So what do they what do they look like to you guys? Hmm?
Just
Like what?
Crystals?
Yes, that is written here, crystal. What do they look like?
Squarish?
Pyramid. Isn't it?
Yes.
Yes, they like pyramid, or you can also call the envelope crystal. You know, the have you seen the envelope where they used to put the letter and send it to someone? Nowadays we have email, so it looked like an envelope also, or you can say it look like a pyramid. So you have to remember these two names to for the calcium oxalate crystal. This is how it calcium oxalate crystal look like. Now, this is a triple phosphate crystal. This is a triple phosphate crystal. You can see this also look like more like envelope or some sort of diamond-like thing, but it is more like of an envelope. So it is a triple phosphate crystal. When there is a breakdown of muscle tissue, the phosphate can come out in a large quantity. So this is a triple phosphate crystal. You can clearly you can see them under the microscope. So this is about it. And now I'm going to show you some of the video here. So there are three videos. Urinary analysis demonstration. Its video will show you how do they examine the urine, and then you have a urinary analysis lab test by using the dipstick, and then preparing the urine sample for the microscopic examination. So let's watch the first video. When it will start, I will share with you the tab. Okay. You cannot see the video now, right? Okay. Can you see now? Can
Yes,
you?
now it's visible.
Okay, I will play the video. Let me know if the audio is there or no.
Urine analysis.
Yes, we
Urine
can hear.
analysis is an important.
Sorry?
We can hear, yeah. We can hear.
Okay, good. So, see this one, how is she doing and what is she doing actually?
Part of diagnostic aids in the clinic. We generally do an organoleptic test of urine. For this, we have to examine the colour. Urine should be a nice, clear yellow colour. We also check the smell. And we're looking for sweet, acrid smells, which can indicate bacteria in the urine. A putrid smell, which can indicate that the urine is very old. There are also some drugs that are able to be picked up in the smell of urine, such as vitamin B12. We also check the turbidity of the sample. And by turbidity, we mean the sort of particles. Are there any particles that are visible to the naked eye? Once we've completed the colour, smell and turbidity tests, we start with a dipstick. Prior to commencing a dipstick test, it is important to check that they're actually in date. So check the expiry date to ensure that it is functional to use. Also check on the side as to how many seconds are required per test. Some will vary depending on the type that is purchased. Some will require 30 seconds prior to reading the result. Others will take up to 60 seconds. And some brands have a mixture of 30 and 60 second waiting times. So it's very important to check that. Again, wearing your PPE because we are dealing with a biological possible hazard. Remove the lid from your urine. Remove a test strip from the pack, ensuring that you don't touch it with your hands. And then fill your pipette with a sample of urine. You can then place a drop individually on each test pad. Wait the allocated time and then tip the excess urine into a suitable receptacle, whether that's a kidney dish or it's tapped on to some absorbent material. Ensure that you check on the packaging which way you are to hold the strip to read the results. And then document the results that you get from the test on your result sheet.
So this was the urine analysis test. You see how she first did the physical examination that you had studied in the first year. Then she did the chemical examination by performing the urine dipstick test, and then she compared it. So it hardly take roughly about 2 minutes to see all the things. And as I told you previously, they used to perform all these tests separately. That would require at least 1 hour or so to finish the urine analysis for one sample. So in this way, this just like in 2 minutes you get all the things ready. Now I will have the second video for you guys, which is again the dipstick but in a different way. So I want you to see this one also. Okay, let me share this with you guys. No, this one. Tab.
Hey guys, it's Mara. Today I want to talk to you guys, teach you a little bit about your dipstick or urinalysis. There's a bunch of names for it. But usually you can get a urinalysis or you can get a UA with micro, and that would be the dipstick part along with spinning down the urine sample, looking at the bottom part, the sediment, and seeing what kind of stuff's in your urine: white cells, red cells, bacteria, mucus, crystals, just any and everything. So, today we're just talking about the dipstick part. If you want to check out some of my other videos, I've put up some microscopic urinalysis videos. But anyway, okay. Now we have instruments that detect the color and decide on the range, how good or bad it is, I guess, the numbers. But originally they held them up. I think they read them after like 30 seconds. I think that's what the instrument does. But compare them to these charts on the bottle. So the first one I want to talk about is specific gravity. So you can tell it goes from a dark blue to almost like an orange color. The specific gravity on a urine basically tells how much stuff is in there. So the specific gravity starts at 1, and that is the specific gravity of water. So if you were just peeing out straight water, then it would be 1. But if you have more mucus, more bacteria, so you have protein in it, things that just take up reflex, light, whatever, then it can be higher. And then the range goes up to 1.03. So the next thing is pH. So that goes from 5.
So here, guys, she is explaining you all the abnormalities, okay, along with their some of the what do you call, some of the diseases that can cause, for example, change in the pH, change in the specific gravity, change or the presence of the glucose in the. You can copy this link, and I would request all of you to watch this at home and try to understand what she is, because it is a 10-minute video and it that would take a lot of time. So I would request all of you to copy down this link. Can you copy down the link? Hello, guys.
No, we can't. If it's the presentation on urine, we can't put it there.
Okay, I have put it here in the chat box. You can copy it from there. And there is one more video which I want you to see. That is the microscopic examination. That is how to prepare the slide for the urine and how you can examine it in the under the microscope. So that is something else. So
Everyone, welcome.
okay, let's stop presenting, and I will.
Back, we're going to be doing the manual microscopic of all of these specimens that we just did on the Criterion 2. The hard part about this is the one that's in the sundouts tube. It needs to be in a conical vial like these guys. And so there needs to be, a place where everything can settle and make a pellet, as you can see down there. And what we're going to do is we're going to take the urine, the supernatant, off after we centrifuge it down to 1 mil. And then we're going to analyze it on the microscope. I'm so excited. Okay, so we're going to, again, invert like this. Okay, we can pour it off into the conical vial. We need 10 to 12 mils. As you can see, it is yellow and clear. Okay, you can see right through that puppy. And let's see, we have just under 10. That's going to be okay. You get what you get and you don't throw a fit. All right, so I'm going to get a cap, get a little cap. Hopefully that's going to sit nicely in this guy. Okay. Sometimes these caps don't work really well. You can also parafilm the top of the tube if you need to. Oh, there we go. We got it. Yeah. Okay, so we're gonna put these guys in the, I know that looks horrible. We're gonna put them in the centrifuge. Okay, but what we need to do is we need to make sure that our centrifuge is at the right setting. So here we have your analysis is 1800 for 10 minutes. Okay, so I'm putting them in first, and then you want to balance the centrifuge, obviously. You want to put them into the buckets that are big. Okay, not the little ones for the blood tube. So if you see, I need to have a balance here. And so I got a balance. This one's just water. And when we balance our centrifuge, we're gonna make it so that it goes across the rotor, so that it's balanced across the rotor. Okay, here's the rotor, and it needs to be balanced across the rotor. So we did that. Okay, that comes down in very high force. All right, so now what we're going to do is we're going to program our urinalysis setting. Okay, so we're going to go with speed. Speed is going to be 1800 RPMs. I can just press the down button. Oops. Goes up by tens. Okay, so 1800, and then we're already at 10 minutes. Okay, so we can go ahead and press start. And it's going up and it's starting. All right, I'll get back to you when it's done.
So guys, this urine is put in this centrifuge machine because she want to have microscopic examination. So for microscopic examination, you cannot just take the urine sample. You have to spin it so that all these heavy things that you want to see, for example, bacteria, crystals, cast, and all the other heavy things that you want to see, they can settle down in the conical tube when she is spinning it. And this machine is spinning it. This machine is spinning the urine sample at the speed of 1,800 round per minute. You can see here, it is written there, round per minute. So in 1 minute, machine is spinning for 1,800 time. So, and this is done for 10 minutes long. We are going to speed up little bit so that here
Kind of slide for your analysis
So,
when you do the microscopic. It's
so-
the Eurosystem DECA slide. And what's that DECI slide? And what that means is that we have 10 wonderful windows here of where we're going to put the urine specimen. Okay, and notice, kind of like a hemocytometer in regard to you put the liquid in there, it's like a wet prep kind of deal. Okay, you would not use this for wet prep for stools or anything because the stool is too thick to put it down in there. So you would use a regular slide and a cover slip, but this is just for urine. And so what you do is you spin the urine down as we're doing right now in the centrifuge, and you take the supernatant off until the specimen is down to 1 mil down here. And everything that's down here is going to then be resuspended. And we put that resuspended suspension in here when it's on the stage, the microscope, okay? So when you're moving your microscope holders, the pins, you want to make sure when you turn it on, the beam of light is going through the window that you want to use. Notice that if you do use Windows 1 or 10 or, the ones on the periphery, especially the ones over here that are on this pin, sorry, oh man, come on. It makes it so that it's kind of difficult to get it so that it's not, going to fall into the microscope. So you might want to start with 2 if you want. Some people go through and they mark an X on ones that they've already finished. You don't have to do that, but it's always an idea. You do not go on oil with this one, okay? So you just end up on 40 or 400, if you count your ocular. And that's where you're going to end up doing all of your counts and your visuals, okay? You start off at 10 first, and you're going to scan the entire slide, okay? You're going to look at the periphery, because if you do, you might find things that you don't see when you're counting, okay? So a couple of things that you want to know is that the casts, they go to the outside of the window. So they're going to stick on the perimeter. And so if you don't scan the entire slide, then you could miss out on that. Especially since one of these we had really high protein, we'd expect to see casts there because we have glomerular damage, and that would be damaged. Fuse time, we're pulling off the supernatant.
She is removing the
You
top.
don't want to just dump the tube.
She is removing the top, which is not required. What you need now is what is settled down at the bottom. So she will take the sample from the bottom, and then she will put it under the microscope. She is doing it, and there.
That way, if you need to do any gravity or bilirubin, sorry. All right, so we're still pulling this off these and putting them on.
Now she will put the sample under the microscope. So this is basically the slides she is using.
Right, so
In one slide, you can
resuspending.
put have a examination of
Remove
10
the
samples.
the objectives. Okay, and then we just put one good drop. That kind of squirted out there. Didn't expect that to do that. I'm resuspending this one too. I think you can see that. No, you can't. Oh well. Okay. I've got, okay. I overdid because I was trying to get a picture, so we're gonna end up in window 5. Oh, come on. 9. We're going in window number 9. Stinking thing. 8. I've never had this problem before. Okay. Now, it's kind of great that happened. Makes me feel ridiculous, but you don't want to ever do this and then reuse that window, because then if there was a drop here.
So this is it about the. I have pasted all these the link for the 2 video in the chat box. You can copy it from there, and then you can see it. So if there is any question, I am here to answer that. Otherwise, it is just a wrap up. Any question?
No, thank you.
Most of you are gone now. Was that so important?
Doctor?
Something else? Yes, please.
Do we need to know the old methods for measuring the protein and such things?
You do not have to know the whole detail of the method, but you must know the name. What is the name for the test which is required for the protein?
Okay, thank you.
Okay, you do not have to know the method. Okay, thank you very much, guys.
Thank you, Doctor.